she was actually intubated because her condition was very tenuous. That's a condition known as sepsis. So anyway, then they called me up and said, Dr. Stanley, please, we'd like to admit this person into the ICU. I was the senior resident in the ICU that day. So, of course, we accept this patient, continue the therapy, and then really the investigation kind of starts. Like, what happened? Like, how did this, like, otherwise normally healthy woman suddenly, why has she got this infection going on? So, of course, we asked her husband, well, what do you think happened? And like many husbands, he kind of scratched his head and said, I'm not really sure. I don't really know. I'm here along for the ride, but if you ask me, I know she goes to a doctor. I don't know what medication she's taking. I don't know what allergies she's taking. But I have these 2 kids now that I have to worry about. So can you call me later? It's sort of one of those scenarios. We called her primary care doctor down in Texas, who, because it was a holiday weekend, was unavailable. The covering doctor then was very nice and said, but I got bad news for you. I don't have keys to the chart room. Now this is sort of a small medical practice somewhere down in Texas. They didn't even have an electronic medical record, so never mind data interoperability. Like even physical interoperability was impossible. So he said, let me see if maybe I can find some secretary. What's that?
You're standing in front of the projector.
Oh, I'm sorry. So he said, maybe I can find somebody who has keys. I'll call you back. So then GI came along, thinking about the liver. They performed this rather invasive procedure called a ERCP. It's a shortening of a very long name. Basically, it's a camera that goes down. They're looking into her liver, trying to figure out what's going on. They said, well, we can't really figure out what's going on, but it's clear she has some sort of an infection. They did another ultrasound, and they saw a little bit of fluid around the gallbladder, but it's not really a clear infection. It's just a sign of some inflammation going on. So with all this, we gave her more antibiotics, more IV fluids. We continued her on the ventilator. On day 3, we finally got a call back from that covering doctor who said, well, I don't know. Apparently she saw some sort of a rheumatologist recently. I don't know what it's about, whatever. And so we called that rheumatologist, who, again, because it was a holiday weekend, was unavailable. But we left messages with their answering service. Still couldn't figure out what was going on. And at this point, this mother of 2, her condition was actually deteriorating. And it was actually a little bit of a scary episode because we talked to the GI people. They said, well, we think she has an infection going on. Maybe it's acute hepatitis. And we drew lots and lots of labs trying to figure out what, is this a viral infection, a bacterial infection, what was going on. and because her blood pressure was dropping, we actually started to have conversations with the husband, who was wondering, how's my wife doing? And we're like, well, we're really hoping that she's going to pull through this. So we continued the therapy. Finally, on day 4, we get a call from that rheumatologist who basically tells me on the phone, wait a second, let me guess, are her liver functions elevated? And I said, yeah. And does she have an elevated white count? And I said, yeah. And he said, it's not an infection. She has an autoimmune disorder called lupus. It's a very unknown, he said, she has a very strange variant of lupus. It doesn't show up on the test, but I've been doing this for 30 years. I can tell you she doesn't have an infection. Stop all the antibiotics, give her steroids to calm down the inflammation that's going on in this autoimmune reaction with her liver, and she'll get better. So sure enough, we stop the antibiotics, we give her steroids. Literally within 24 hours, her blood pressure came up, she was doing better, her liver function panel went down, her white count went down, and I'm happy to say that this was actually a happy outcome because she actually got to see her 2 kids again. And her 2 kids didn't have to hear that mom died because the right information wasn't in the right place at the right time. And how would I, as a doctor, have explained to those 2 kids, I'm sorry about what happened to your mom because we just didn't have the information. So that's why we're doing this. And that's why I'm very passionate about everything. I love meeting all of you. This is a great place to be. And so I really think people, I hope everybody here realizes that everything you're doing is actually improving patients' lives, making things possible. avoiding costs of unnecessary care, and it's really important. So thank you all for what you're doing. So with that in mind, so with this interoperability thing, I thought, I would love to speak to a couple of experts on this, like maybe I could put together some sort of a panel where I could like talk to some experts. So I'd like to invite some of those people up here. So I'd like to invite Mike Gagnon, Jeff Loughlin, Beth Eldredge, Steve Maier, and Rebecca Bonds up as our panelists. So, all right. So these are the 5 people now. So by the way, one of the nice things about being a physician in this field is that I get to sort of like ask all the questions and let the other people do the thinking. So in alphabetical order, I'd just like to introduce these 5 experts that we're going to have. Rebecca Bonds is a strategic consulting senior manager for Leidos. She has over 30 years of broad experience in the integration of health systems to support the delivery of care and financial operations, including project management, something very dear to my heart, and consulting for providers, payers, and government agencies. She's provided expertise to some of the country's early ACOs and population health management adopters, and continues to deliver solutions and expertise for several state, regional, and international HIEs. So I'd like everybody to welcome Rebecca. Next, alphabetically, we have Mary Beth Eldredge, who you heard from before. She's the regional IT director from Dartmouth-Hitchcock. She currently works at Dartmouth-Hitchcock, which you've been there for 20 years. That's unbelievable. Wow. Bravo. And she's also the board chair for the New Hampshire Health Information Organization. She recently got her master's in healthcare delivery science at Dartmouth College, and she has the bragging right of saying she knows everybody in the 2 states of New Hampshire and Vermont. That's pretty cool. So I'd like everyone to welcome.
I will.
So if we can welcome Mary Beth. Mike Gagnon, who you just heard from earlier, is the Chief Technology Officer for Vermont Information Technology Leaders. He's a senior information technology professional with over 30 years of experience in diverse areas, including healthcare, defense, academia. He's former president of the Health Information Exchange Partners, a private healthcare consulting firm with a focus in HIE system architectures, planning, technical assessments. He's been involved with several HIE projects in New Hampshire, New York, Wisconsin, and Michigan, and was the lead technical architect for the Michigan Health Information Network, the MHCDS. So thanks, Mike, for being here. Jeff, we just heard from, again, the bios are available, but I'd like to point out that Jeff works with providers, practice leaders, and clinical administrative staff as part of his work with the New Hampshire Health Information Organization. He works to ensure successful adoption of health information technology and implementation of the statewide health information exchange. So thank you again for being here. And finally, we have Steve Maier, who is a healthcare reform manager. I love that. Healthcare reform manager.
The only one who has ever said that.
Wow. That's great. If we just need an international one, that would be great. Okay. Healthcare reform manager at the Department of Vermont Health Access, Health Information Technology Plan. He helps to manage the integration of diverse health reform initiatives with special expertise in the expansion of HIT resources to mental health and substance abuse providers, also something near and dear to my heart. Thank you. He also assists in the statewide implementation of Vermont's Blueprint for Health. He served in the Vermont legislature. We actually have a real politician here. So, from 2003 to 2010, including as chair of the House Committee on Healthcare from 2007 to 2010. And he co-chaired the Vermont Healthcare Reform Commission, which is a quasi-legislative body that has guided sweeping healthcare reform legislation. So thank you all for participating in this panel. So knowing now that I have these 5 experts that are here to help answer all my questions, I thought, what am I going to do? What are the 3 questions I could possibly, hold on a second. What are the 3 questions that I could get them to answer for me? So the three questions, as we were talking about it, that we came up with were these. And I'd like to start off with the first one. Okay, so the first question I thought I would ask these people is about health information exchange. And we had a little phone call, and it's very interesting actually speaking with these experts, because as a physician I learn from everything that they say. And there was a lot of discussion about the health information exchange, you know, what the challenges are both inside the state, and there are regulatory issues inside, and how do you manage it when you're functioning across state lines? What do you do when, like, you know, you're playing baseball and the other side is playing cricket? That's a great analogy. So, so I'd like to ask this panel, the first question is, what do you see as the biggest in-state and across-state challenges that we're facing today? What are the biggest, both inside the state and outside the state? So is there anyone who wants to start off with this discussion of in-state versus across-state lines?
Sure, I'll start. Thank you. In-state is kind of the volume and, as the guys at IBM Watson Health said, it's the veracity and the volume and the velocity of data. And that means that, you know, we're at our summit just last week, and Dr. Abdullahi, who was the Chief Science Officer, said it's all the data that you are trying to collect on patients. And interestingly enough, the clinical data was only a small portion of what impacts people's health. And so trying to get into other forms of data, like social data and housing data and all this other kinds of information. I mean, what has happened to our network is we're starting to realize that we only have a small bit of what we need. And so in our state, it's that broadening of our data set, and then, as I spoke about earlier, you know, the quality of the data needs to be there. And so those are kind of the two big in-state things, is breadth and depth and accuracy of that information. Cross-state, we run into some more interesting challenges, often in terms of exactly what we spoke about here, in terms of the fact that patients don't view state lines as a barrier to anything, but legislatures and others have become really interesting and complicated in terms of that. And let me give you a simple example, or maybe it's not simple, but the consent policy between New York and Vermont is quite different. And we've been trying to work with our sister HIE in Albany area, HCSCNY, who's also has a very robust HIE and has been around for a long time and very savvy in terms of what they're capable of. And we like to think we're pretty savvy about what we're capable of too. And we have not been able to get off the ground because of the way their consent policy is organization by organization opt-in, and Vermont is global opt-in, and that one fact alone, along with the fact that they figure out how to get 42 CFR Part 2 data into their network, those two things kind of grind this to a halt. And it's not ground because of technology or patient need or desire or anything else. It's ground to a halt partly because we just can't figure out how to get through those differences in our two states. And so I think we're going to find that more and more. National guidance would be helpful. Healthy Way doesn't really solve this. You still need to have a data use agreement between states that says what you can do, but you can block any data if you don't like the policy from the other state. And so what I think is going to happen is a lot of people will get connected, and then there won't be access to a lot of information because you just can't work through the policy. So we're having to change the way we do things on our network, and I've been working through how are we going to do that on our side so that we can gain access to HCSCNY data. Just as Dartmouth gets a tremendous number of their patients from Vermont, the University of Vermont Medical Center gets a tremendous amount of their patients from New York. And so we've got to figure out how to make this stuff work, and like many things in HIE, there's no easy or direct way through it. It's simply just working it piece by piece by piece and step by step, and it's just dog work, I like to say, but it's all just for the reasons that Dirk was pointing out, is we're not going to stop. We're going to keep going.
Well, I have to say, I appreciate Mike's boundary questions or comments, because that is my passion, that we need to start working across state boundaries My favorite line is that Northern New England has 3 HIEs. We have 3 million people, 3 states, 3 HIEs. And our patients don't follow state boundaries, so I'm very happy to hear you say that. I think, as I think about some of the challenges that Dartmouth-Hitchcock is facing with health exchange, I think about the very simple CCD exchange. And technology standards aside, we all know that is an issue, and Neo's going to try to do some work on that and hopefully steal from them. The challenge of changing the workflow with the CCD and getting that value in front of the clinicians and the others who could say, yep, there's some information in here that I could use. If we can get that value in the CCD, how do you affect that change in the workflow? We've been working at this with a couple of our local hospitals for what seems like a year, and we can't get beyond the technology piece. We can technically exchange the CCDs, we know we can bring them in, we can map the data, we can do the med reconciliation, but getting it into the clinical practice is a huge, huge challenge. And we are struggling with it, the London Hospital is struggling with it, Cheshire Medical Center practices, and I think that's the big piece of how do we now engage the people that are using the data to say, yes, this is something that could be of value, help us make it of value, and then let's change that workflow from that fun faxing that we do of all the patient records, all of those medical records.
Good morning. I think I might be the only non-IT person. I'm not sure about Rebecca up on this panel. So, and as a former legislator, I think my role here is to talk about other sorts of things. So I'll just throw out there several other challenges that this landscape encounters. One obvious one is funding. Another one is patience. I mean, it's really hard because we all want it to work now, and yet most of us, if we really were truthful, we would say this is we'd be guessing, right? Is this a 5-year project? No, it's long. It's at least probably this is a 10-year or longer thing that we're all working on here. And so the idea of how do we get there from here, and how do you organize your work? Which projects do you focus on first, or fifth, or much later, and how do you explain that to people? And then how do you deal with the frustration that people have? Right, we have this Jekyll and Hyde thing that goes on all the time in our work, which is that half the people we interact with are yelling at us because the data isn't there. They expect that this all exists already, right? Because it exists in every other part of their world. They turn on their smartphone, their health app, whatever. And where's that data? What do you mean you don't have that MRI in your EHR that I took last week at this other? What? And then on the other hand, the other half of the people are yelling at us because they're worried about privacy and security and all this other stuff. And so that there's a patience component and the custom and workflow, as Mary Beth just said, all of these things need to change, and the process of change we all know is hard and it takes time. So I'll confine my remarks this time to those two sort of non-technical areas. We've done some good things related to funding in Vermont. So policy drove legislative action around funding that's to specifically support health IT, and so we are able to support VITL's budget, which supports 30-some-odd employees there, and a lot of the work that Mike described, as opposed to the situation that Jeff does his best to manage.
So, not just because she's my board chair, but Mary Beth is 100% correct. But I do see, I think the point there is, this is from my perspective, what we're trying to do is an education piece that's very challenging between the states. We're trying to educate the staff itself, the providers, the organizations, how to do the workflow. That's challenging enough. How do we educate patients? We're seeing at the federal level, at least the direction is right. Whether the implementation of the standards and stuff is is it perfect, is it certainly questionable, but at the feds level, we're moving in the right direction. But there's the state level, there's an education piece that's challenging. It's nice to sit with the legislator because we struggle with how do we educate the legislators on what we're doing and how we're doing it correctly. Speaking sort of in the New Hampshire side, there's a lot of concern about privacy and security, and it's a perceived privacy and security because we know from a technical standpoint, an encrypted database is 10 times more, safer than a paper record, except when they're closed off hours or maybe can't get to it. But it's inherent security. I know we're talking about privacy and security later, and I can, from a technical standpoint, I can send data to VITL. That's not an issue, but it's the reason to send it and the safety of that's received is there. And trying to get that the legislative piece of the states start to think in the same way, so we don't have opt-in on one side of the river and opt-out on the other. Again, as Mary Beth already said, from the patient's perspective, it just doesn't make sense.
And I'm going to take us back to our clinical question on the board here a little bit and take it to a more local level with the provider. We're seeing across the United States the providers struggling to meet meaningful use. We're seeing them struggle to enact their transition of care capabilities. And what we're finding is that should they enact their transition of care capabilities under the minimum requirements for meaningful use stage 2, they're still not going to help in this clinical case. Why are they not going to help in this clinical case? Because they are implementing direct. They're doing a one-way communication capability. They're not implementing the ability for the query function that he would need to get his information. So while I say that we are making great strides nationally on providing information, I still question, are we providing it in the right way at the right time? So I'll leave you all with those thoughts and let you move to the next question.
Sure. Thank you so much. So the next question I thought I would ask these 5 experts is really, and I think this resonates about patient privacy. Health information exchanges have this really remarkable opportunity for improving care, but it can also present challenges to patient privacy. So, so I'd like to ask, just for your opinions, what HIE configuration do you feel really offers patients the most benefit for the least cost in terms of privacy and access to data? So I don't know who wants to start with that one.
We're really glad we have Mike here.
I'm the only one who's willing to pick up the mic. Again, I've been in this field for a while now, and if you look nationally, there's a whole lot more states who do opt-out, meaning everyone is in unless you take an action to opt out, than those who do opt-in. And then our friends in New York decided to do organization by organization opt-in. By the way, their policy was much more stringent before that. They had to have a 2-step consent policy where you couldn't even get the data to flow in initially without a consent, and then a second one to get it out. So, I mean, we can go too far with these things, and here's my sense of a little historical perspective on this kind of stuff. We worry greatly about what we hear in the news about privacy breaches and security breaches of stuff, and those are real and have happened. And so that becomes publicized. What doesn't become publicized is when we solve a problem like Dirk was presenting, and the data is there and we save someone's life. I think the conversation has to flip a little bit. We have to do a tremendously good job at security and privacy. We must. We have one of the most important data sets that anyone is ever going to have. It's complex. It comes from a whole lot of different sources. It is an incredibly important thing we have to do. We've chosen at VITL to go with what we think is one of the highest standards for security, and that's the NIST 853 high-level security. And so we have to take that seriously. But the other side of that is, what is the downside of information getting out on someone who did not want it to get out? So the privacy side. Okay. You may hurt someone's job, you may hurt someone's reputation, or maybe something, but what's the downside of holding information back that was needed for the clinical care of someone? They could die. And so to me, we aren't having that conversation right. I mean, you know, and you still get your own choice. If you don't want your data to be there and you want that risk, you can make that choice in our network. But to me, it seems like the risk on one side far outweighs the risk on the other side. And that's not a risk. Bad things can happen to people if their data is breached and gets out. But really bad things can happen to people if the data is not there because that you need to treat someone in an emergency or care situation. And so, you know, that makes it always a really challenging discussion. There's a very vocal, small minority who wants things really locked down. To legislators in New Hampshire blocking HIE effectively versus, you know, the other side, which is kind of inherently, we know we need this information, but I'm not, and by the way, a lot of patients think, we're already doing this. I would guess if you poll people, 80% of patients think, data is just all wherever it needs to go, right? You know, and no, and it's really complex and it's not happening. And so this is always a really challenging topic to get into when we start to, we've had consent discussions for the last couple of years, and every time we start to have one, I go, oh, here we go. You know, I mean, because the belief systems of people get involved in this kind of stuff, and so it kind of starts to spiral out of control a little bit, but you got to have people have those. I mean, and it's valid discussions to have, but it's a really challenging thing to implement. And when people start to say, well, what if you do field by field blocking of stuff? And I'm going, no, no, stop. We don't just say yes or no. I mean, you know, we have very blunt instruments is what I like to say about what we can do with the data right now. The discussion Steve and I are trying to lead in the state around the substance abuse treatment kind of data, and that, you know, even more sensitive, right? So, that's another challenging one, which gets into all kinds of philosophical discussions about those sides of the people who say mental health and that kind of data should be embedded with, you know, physical health, and that creates a stigma if you keep it separate. But at the same time, people want it to be separate. You know, these are not easy questions to answer. Like I said, it's all dog work. You just got to work through it. There's no easy way through this complex situation. The CEO of One Care Vermont, Todd Moore, said, this is like being in a swamp, and we're trying to get to the other side of the swamp, and the only way to do that is to pick one foot out of the mud, and then take one step forward. And then take your other foot and pick it out of the mud, and take one step, you know, and it feels like sometimes like that's what we're going. And Steve's comment about it being a 10-year plan probably isn't too far off. I mean, this is just, and we're not going to stop going, but we feel like we're moving like we're stuck in mud sometimes, and you know, we can't kind of make the progress we'd like to make. So anyway, that's just comments.
I think the comments about privacy and engaging patients in understanding what it means to share data or not share data. At Dartmouth, we've recently changed some of our policies. I'm sure folks at Grace County are happy about changing our portal policy to an opt-out, not an opt-in, which there was great rejoicing in the clinical community for that. But we've changed our opt-out form to opt-out of all electronic exchange. And so if a patient wants to opt out of electronic exchange, they opt out of VITL, sending through NEO, Care Everywhere through Epic, and DH Connect, our physician portal. And in that opt-out conversation, we try to explain what this really means. And so you can check out our opt-out form on the website, but it basically says, you know, there might be duplicate care. You might get more tests if we don't have the ability to exchange. There might be delays in communication. We're not going to use secure technology. We're going to have fax, we're going to have mail, we're going to have things around. Really trying to explain to patients, and our privacy officer talks to every patient that wants to opt out, to say, you know, you really need to think through this, what this means, and we do comply with HIPAA, and we do have minimum use necessary, but understand how this affects your health care. And so I think that piece back to you, see, how do you have the patients understand what health exchange is and how it can help them? We were having a conversation the other day about what do patients need to know about interoperability, and we all said nothing. It's like a power company, it's like a utility. but they need to understand how their information is used to impact their healthcare in a better way, whether it's cost, quality, geography. So I think that's where we need to start looking in the privacy space. That there's, you know, Jeff mentioned our legislative body. We have 400 representatives. It's a lot of education to do one at a time about privacy. I think the bulk of folks want their information shared, and except for those who don't.
Anybody else want to go? I'm not sure I have much to add to this one. I was going to talk about the comment you made the other day about interoperability, but and then I think it's just, I'll go back to the fact that just most people, when they get to use it, and we could all go back and brought up the banking analogy. I know Mike, I think maybe goes crazy whenever we bring these up, because it doesn't exactly apply very. The complexity of what we're trying to do in healthcare is actually a good deal deeper and broader than it ever was in the finance industry. But still, the idea that, you know, when you first had your opportunity to do your banking online, right, you were all, you know, like, pretty nervous about it, and exactly how does it work, and where does it go, and all those questions, right? And now, right, just do it, and it's on your phone, and you can deposit a check, you know, all these things that you just do, and you don't think about it anymore, you take it as a given, right? So some time and development needs to happen before we start to get to that place.
I was going to add, I can't really answer the question. I was tying back to your example earlier. It scares me that the husband or the father didn't know didn't know that diagnosis. But I don't think he made it here. But I had a conversation with Darryl Bodnar for weeks. He's supposed to be here today. You know, meaningful use has helped, you know, sort of put patient education and patient engagement into the window. But at the same time, it's actually fragmenting the patient side quite a bit. And to use his example, since he's not here, he's a very small critical access hospital in northern Hampshire. He's got because of the meaningful use purposes, he's got a patient portal for his patients, but he has one patient portal tied to his inpatient system and another patient portal tied to his outpatient system. And the two of them don't talk. And so as a patient, you know, your care, if you happen to see 3 or 4 different providers, and the sicker you are, the more providers you may have, you know, we've seen patients that have 4, 5, 6 patient portals disconnected. And you know, there are apps from time to time that you can try to aggregate yourself, but there is no sort of, you know, level playing field for a patient to say, you know, where's my centralized repository of data? And I think there's there's a strategic piece in there for organizations like NHIO to try to figure out if we can help play in that space somehow. Certainly with organizations like VITL, because they have that centralized data, there's a greater opportunity. But I think, you know, now's the time that we have to address that before, you know, we focus just on the providers and the care coordination, critical piece. But if we're making the patient side more fragmented, it's going to be challenging for them to be supportive, and, you know, they could have the answers for you. Have that data.
And I think you took the words out of my mouth. I was going to say that exactly. We are fragmented in our patient portal capabilities today, and we have to, along with true patient engagement, that true patient engagement includes education, and it includes taking that time in the office visit, that time at the healthcare facility to actually sit down with the patient and educate them. I see a resistance to taking that time. And the key vital area where we can take that time is that relationship with the primary care physician's office. That's where the trust factor exists today, and that's what we need to capitalize upon. From a technology perspective, we need to focus on patient portals, and I think bringing that up to an HIE level is part of the answer. I think that's something that we owe our healthcare environment to invest additional funding and additional working.
So, thank you again for the expert opinions. That brings us to our last question that we'll raise to the panel. And by the way, one additional feature of this case that I'd like to just point out, this whole case could have been prevented by the mother apparently bringing her medications with her, as many mothers do. She put her kids ahead of her. And so when they were packing up for the trip, she made sure that her kids had everything that she needed, and she forgot to bring her medication. And I can only say that for everyone else here in the room, if you live with anyone, make sure that you know what medications they're on and what their allergies are, so that you can help prevent scenarios like this that happen. So that gets us to our third question. And since we're bringing up all the patient engagement and the very patient-focused technology, I thought I would ask, with the advent of smartphones, patients are becoming increasingly engaged in their healthcare and management of their health information. Do you guys know about e-patients, who these people are? They're like on Twitter and Facebook, and they're actually starting to like really ask good questions. Dave DeBronkart is one of their staunchest advocates, and he really talks about the patients owning their data. And so with this sort of like really patient-focused to healthcare data, I thought I would ask the question to the panel: what should patients actually? What do you think they need to know, and what don't they need to know? And when I bring this up, I'm asking about sort of in a political sense, like what are the things that you think you wish that patients knew about health information exchanges? So does anyone want to start that?
So, issue of e-patient Dave lives in New Hampshire, and that we are also struggling with the legislature. So I think what they need to know is how they need to educate, especially folks like Dave, because he is so well versed and knowledgeable in this space. How can we use folks like him, or how can he leverage his community activism work to get organizations to help us educate the legislators? Because I think they need to know the benefits, the security of electronic data, what it means from a provider standpoint, that they can leverage that functionality in their EHR to make them better providers, provide safer care with all the alerts and reminders, and it's transportable. So when you do go to Florida, you go skiing in Vermont, that data can go with you to some degree, whether it's on an app or on a central repository or simply sent electronically. That data is available. So I think it's incumbent on folks, at HIE organizations to sort of circle the wagon with those types of folks and help them help us educate and move forward.
I think patients will get more engaged. We all will be more engaged in our health record when we have a more active way to contribute to it. And so I think if you sit with a bunch of providers or whatever, the idea that patients could actually go into the record and like change something, or more easily just add some information. I mean, how many people have Fitbits? Something? I don't, but
I am raffling one off. I'm raffling one off.
My new iPhone does that for me. Calculates how many steps I do, whatever. I remember to look at it, but at a minimum, right, you ought to be able, the patient ought to be able to start contributing that to something other than their own. I mean, right, it goes somewhere, but it doesn't go to a health record that any of my health providers could see. Can patients, right, we don't really let patients, if you have access to a portal, and by the way, right, most of them are horrible, right, you don't have much, there's not much there. So in addition to them not really being very good functionality, we have to then have 8 or 10 of them, right? So Rebecca suggested elevating it to the HIE level, which would be one great step. But I'm not convinced that the portal is actually right? It's going to be just like Mike was saying much earlier about the provider portal being an obsolete technology already. I think patient portals aren't going to last very long either. They're going to move quickly beyond that to these apps, to our smartphones and other applications, and the ability to actually start to contribute data or adjust data within our health records. I think that'll be a real mark of positive change.
So the pharmaceutical companies have taken on this patient education thing, haven't they? They start to market their medications, and whether that's good or bad is neither here nor there. They start to market directly to the consumers at the kind of the end point, and of course they also also say, and the side effects of this could be death or whatever, you know. But it brings to mind a kind of interesting topic about when you're having that discussion, as Mary Beth was saying, with your patient about, if you say opt out here, side effect could be what?
We don't really see that.
Yeah. Okay, I was going to say that in that concept, but you know, your provider will not have all the data to treat you. You know what I mean? I'm not sure we're having that detailed conversation yet with them, and I don't think they understand that. I'm guessing that when most people go in and sign our consent form, more than 50%, probably 75%, sign that thing because someone handed it to them. And they want to get whatever they're treated for. That's what they're there for. Have you read all the, whenever you download an app on your phone, do you read all the privacy things that are out there? And the whole entire thing? Do you know that they can turn your camera on and look at you and listen to your background noise and figure out where you are? There's a whole bunch of things in there that you don't know, right? So people do this without thinking more, and that actually is worrisome to me. I mean, I'm glad they do it. I think it's generally a positive thing for them, but I think they do it without us really educating. Well, that's a huge task of ours, to educate them on the value, because then it can turn around and help folks like New Hampshire, because if the consumers were involved in this and understood that this value is being withheld from them, I call it withheld, but you know, the ability to query this data would be a really important step forward. You know, we're doing it and it's really valuable, and I think it might change the discussion, because then it's coming from those who are directly affected, the 42-year-old mother, you know, too. I mean, I think those stories are compelling, right? And I think people in today's world actually share a tremendous amount of data. How much is on Facebook about you, you know? And like I said, the phone apps you've got, and you don't understand how little of your privacy is protected with the things we're doing today. And yet we treat this one that's life or death on you, like, and again, it's partly because healthcare organizations have not always been really on top of their game about protecting this data always, right? The fact that there's been these breaches, and when you usually look into them, they're pretty mundane stuff. The operator went home with the backup tapes in the back of his car and forgot to bring them to the site he was supposed to deliver them to, and they got stolen. Oops. You know, I mean, that stuff like that, laptops without encryption on them, really? That's so easy to do now. I mean, and some of the things that are done are like, give the rest of us who are working really hard at this a bad name, you know what I mean? And it's not that we can't be breached. If someone wants to breach us, they're going to. I mean, that's it. But what we want to do is keep a low and a difficult to profile to make it as hard as possible for that to happen. And then, you know, if that is happening and they can trust us to do that, then I think they're going to be much more open to that other side of the equation. And if 80% of the people think we're already doing it, then we've got to educate them that we're not. Which means we've got to fess up. We've got to fess up and say, this isn't happening. And it's going to take a lot more work to get it to happen. And they'll be outraged, right? I think my doctor has an electronic record. I think electronic health records are an important and excellent first step, and that they are driving some thought processes in the wrong direction, because no matter how good they are organization-centric. They are not patient-centric. And only when you get to the network and the network of networks level, kind of national level, do you start to really create this value. Let's put it this way, there's extreme value inside an organization to have on this thing. But there's also tremendous value at the network and the network of network levels that, we're just starting to see the value proposition be exposed from the, you can't do population health inside a singular EHR. If your patient is seen effectively 4 or 5 EHRs. Patient portals are not useful if you get 8 of them. Should there be 1 at the state level we talked about? And then, is it really even the state level? Because again, patients don't care about state boundaries. Would we let anybody in? Just pay us a small fee, collect the data, so how do we get past this? I mean, it's a good start. I like to say we're at version 1.0 of health information technology. Having been in the field of technology for a long time, we're early in this. If we're just starting to collect the data in many small practices, and a lot of them still don't have EHRs. That's version 1.0. Okay, more advanced medical centers like UVM and Dartmouth are doing things that are way beyond 1.0, but not as a statewide or regional or national network. No, we're still early in this process, and it will get better. Standards don't become the de facto until there is a strong business case for them, until the payment system really turns to value-based. Fee-for-service is going to be a barrier to interoperability. And so that's kind of I think there's several things that have to happen, and they are happening right now. We're in a huge change period in terms of health information technology and healthcare reform in general.
Does anyone else want to offer? I just want to keep track of the time. Anyone? Do you have any other thoughts about?
I'll just stand up to add one more comment, Mike's last comment about, so some of you have been at some of the events we've been holding in Vermont around revising our statewide HIT plan. And one of our consultants at each of our, almost all of our events, to bring home Mike's point, if you compare where we are in the HIT development to the process of developing automobiles, we haven't yet invented the electric starter, right? So we're out there starting our cars, you know, like this. and that's where we are with this. And so hopefully it'll be less time than 80 years it's been since there's been electric starters. I don't know exactly history, but
Interestingly, I was looking at those statistics on the flight here yesterday, and 3.7% of our hospitals reporting to HIMSS have reached stage 7 EMR adoption. That's equates to about 202 of the healthcare hospitals, hospital staff, who are participating in that survey. So when you think about 202 nationwide have reached stage 7, that's huge. We are in our infancy at this point. We have pushed out HIE a little ahead of the market. We built it and they will come. Well, they're still coming. So we have to be prepared for that. We have to put in place the mechanism to address that long term, not just in the short term.
So thank you all for this excellent discussion. I'm so glad that I can come to these things and have experts answer these questions. So thank you. And I really want to just make a thank you to everybody for being here, because again, it really is important to patient care what you're doing. So everyone is making a big difference. I want to allow a couple of questions. I don't know, were there any questions for the panelists? Is there anything you wanted to ask? Sure.
Jim Harris. I'm wondering what you heard in Vermont. Is opt-in or out or opt-out in relationship to generation? Have you done any studies on that?
in relation to age?
People have less care about opting in.
Have you looked at your opt-in statistics related to age? I think that's the question. Do younger people opt in? We all sort of assume that younger folks are more. I think what I've read actually is that there's a sandwich here that people beyond a certain age tend to opt in because they just trust the things. You know, so if you're over 70 or something like that, I think a large percentage of those folks do opt in, and then folks younger than 40 or 35 tend to opt in, and it's the folks that are more or less my age in the middle here that are more skeptical. The Watergate generation, perhaps, but I don't know if VITL actually has any statistics on
Judith may actually know the answer to the question. She runs our Vital Access program.
I don't think I need it. So we haven't segmented the data by age, but we do know, and this has been a consistent metric, is that we have a 96% consent rate, meaning for those patients who have been asked if they'd like to opt in, segments that question it most and have a higher probability of not opting in. And the ones who are sort of in the middle are the ones who have a higher probability to opt in, but not specifically age. It's an interesting question.
Any other questions for our panelists?
Just a note that we probably could do that.
Yes.
We have not. We have all the data to do that now. And it might be an interesting topic. I think we also understand that probably, like I said earlier, a lot of them opt in without actually really understanding what they're doing. They want to, or they might understand, this allows my doctor to get my records. Okay, I want it to happen, but I don't think they fully understand the fact that this is a statewide repository. How, we don't really need them to know how it works. As Mary Beth was saying, we need them to know what the implications of this are and what that means. Clearly, those who have more chronic disease and see lots of providers, I think, are going to either be extremely sensitive to it or more likely to want to opt in because they want those doctors to have that information. And either, although younger people are more savvy with technology, they also don't have a lot of episodes, so they're healthier in general. So, it'd be interesting to see how does that work.
Yeah, question? Go ahead.
Yeah, Dr. Gelser, I just came from the HL7 working group meeting in Atlanta where a lot of these topics are, of course, front and center. Before that, though, I established with a new primary care physician who's been an active EHR user on one of the major vendors for a long time. And I noticed he had 3 stacks of paper charts on his desk. And I asked him why, and he said, well, 2 reasons. Number 1, I can't be paperless until everybody's paperless. The other is kind of an interesting new kind of opt-out feature, which is a substantial number of those are records I'm keeping for patients who say, I don't want this in the electronic record because I don't consider it trustworthy or secure. So, and he's had enough personal experience with information that he has made a good attempt to render secure show up insecure. So those of you who are working in exchange environments, in your governance models, what means do you have to capture anomalous events about exposure of information that wasn't supposed to be exposed, and how do you then feed back that into your system to find out why the information did get exposed, what do we do to make sure it doesn't happen again? Because frankly, for a lot of the public, every time they read, whatever our good faith beliefs are in the future benefits of this, when they read about massive breaches at healthcare systems, it does kind of tend to argue against what we're trying to do here. So what if, those of you who are in exchange environments, what is your governance procedure for identifying anomalous behaviors and fixing them?
Yeah, great question without an excellent answer. Not a very direct one to say this. This is a real challenge for us. Obviously, we do all the things you'd expect us to do, right? So we screen who gains access, we give them the appropriate access, we monitor every single event they do on our network. From a breach perspective, we're, again, not immune to anything, but we really put a lot of effort on that part of it, making sure information is not going to leak out. The more likely scenario is one where someone with legitimate access does something that isn't really what they should be doing. And those are hard to find, actually. Audit trails aren't going to give you those very easily without you doing some pretty sophisticated kind of audits. I'm rarely going to find those in a random audit, for example. And so I have blunt instruments for determining those things, although we are heading towards what I call a heuristics-based approach to that, where we try to use rules and logic about the types of things we don't view as proper behavior, like I'm looking up a whole lot of patients that are not from my practice. I don't have a known, relationship with them. Or I'm doing a whole lot of queries all at once for something. Or I'm looking at someone who has the same last name or previous last name that I do, or someone who lives with certain geography I do. Those are, kind of, to me, the more interesting ones, that because what they do is they take looking for a needle in a haystack and get it down to a much smaller haystack of the things I could do. So from a technical privacy security thing, we work hard on all the things we're supposed to do in protecting the network and all of that. So I am less worried, not unworried, but less worried about something where we're going to have some kind of major breach. But I am very worried about the fact that effectively we're distributing our security, right? And that's part of the weakness of it. The other thing is that they just don't know how well individual endpoints do, right? So I'm working with a whole lot of small medical practices who have only so many resources and so much knowledge. We help them if they ask with their security risk assessments and policies and training and such, but not all of them ask. And so while I can feel fairly comfortable about what we're doing, it's hard to feel comfortable about the entire network. And I just don't think that there's an easy way through that. But at least once I become the steward of that data, I treat it with the respect it deserves, and making sure, that it's protected. But again, not an easy answer, but we have a path for the kind of things we need to continue to do to make this a more and more secure network that people can trust.
Mike mentioned that we've been working recently, well, for a long time and recently, on 42 CFR Part 2 data sharing, and that really illuminates this question in a variety of different ways. But one thing I was thinking as you were asking the question is we're really struggling. It's the sort of after the fact auditing that Mike was getting into is actually easier in some ways to understand, what can be done and should be done. What we're trying to do at this point is establish the rules. What are we going to tell the HIE technical system to do, and how are the rules going to work, and when can people access it and not, and what happens when you revoke? Does that mean, what happens to the data that they acted on last week when a revocation comes in this week? And so, and as those of you that have ever tried to understand or deal with Part 2, it's just not clear. It's not clear legally, or there's so much that's not clear. You struggle to understand what the binary rules should be to give to the computer to process the requests properly. One tool that has seemed to emerge organically in two different environments, which helps a little, it helps some, I'm not sure it disposes of the question, but one tool is what we refer to as an attestation screen. So, and VITL actually has this, not just for Part 2, just before you can query a patient within their normal provider portal, a provider, a clinician, has to actually check the box. A window pops up and says, yes, I have a treating relationship with this patient, and it's proper and appropriate for me to be accessing this record. And so similarly, in a Part 2 situation, you could create these pop-up windows, and just this week, we were brainstorming about maybe in every single Part 2, every single time someone clicks yes to give me the Part 2 data, yes, I have all the consents, here's the redisclosure notice, everything else, but every single time, perhaps, it would be like a break the glass incident where there would be an even more robust audit process that happened in every one of those situations. These are some of the things we're struggling with.
I'd like to just add that when I talk to patients about electronic medical records, as a physician and as an informaticist, I often explain that the paper charts were horribly insecure. And I'm old enough to, I'm old enough to have seen medical care in a strictly paper environment and now an electronic environment. And I can only tell you what the behaviors that I saw going on with paper charts would never, ever, ever happen in electronic charts. I would even argue that the fact that we even know about these data breaches is because it's electronic. in the paper world, data breaches were going on every day in doctors' offices all around the country, completely unaware, and there's no record that there was ever a data breach, so that's why it wasn't in the newspaper. So I usually try to, I think everybody here sort of would agree with that the electronic is probably more secure than the paper.
Well, except in the past, if you were going to steal 1 million patients' paper records, it was a little bit more difficult.
Sure.
Than it is now.
Sure, yeah. But I would say that, probably the most egregious, common events were, somebody like, oh, I heard my neighbor is like in the hospital, like, oh, let me just take a look at the chart. Are they doing okay? That kind of thing. And I mean, that was a fairly commonplace activity until I would guess about like 5 or 10 years ago. So, but you're right, in terms of volume of information, absolutely, that's why, all this is important. So, all right, thank you all. We have a little time for coffee now.